Today we'll discuss heart failure, which is a very important cause of high morbidity and hospitalization in our country. It's the commonest cause of hospitalization in adults after the age of 65 years. By definition, heart failure is a condition in which heart is unable to pump blood into circulation according to the body needs. And these patients with heart failure, although there is some blood available to the tissues, uh, but that is at the expense of high left ventricular and diastolic pressure and symptoms of heart failure. We'll discuss in next few slides heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. So you should know what ejection fraction is. It's the percentage of blood that is pumped by heart during each beat. You can see in the picture on the left side there is left ventricular dilatation and the ejection fraction is less than 40 as compared to the picture on the right side in which the ventricle is not dilated. So on the left side of the picture, the patient is suffering from heart failure with reduced ejection fraction. Uh, Heart failure with reduced ejection fraction, which previously was known as systolic heart failure, uh, there is decreased pumping functions because the fibers, myocardial fibers, are damaged, they are diseased, and the ventricle is dilated. The left ventricular blood volume at the end of diastole is high, and the stroke volume and the ejection fraction is low. Whereas in diastolic heart failure, the left ventricular cavity is not dilated. The ventricle is hypertrophied. There is no systolic abnormality, but it's a relaxation abnormality in heart failure with preserved ejection fraction. And you can see in the next diagram, the left side, you can see the left ventricle is dilated, and you can see the uh, mm, red blood in the left ventricular cavity, and you can nicely compare the amount of blood in the dilated left ventricle as compared to the amount of blood on the right side. So in the left side of the picture, the left ventricle is dilated. The patient is suffering from heart failure with reduced ejection fraction. There is increased in the left ventricular and diastolic volume. And now see on the left side of the picture, the ventricle is hypertrophied. There is no left ventricular dilatation and there is no increase in left ventricular and diastolic volume. Rather, the amount of blood in the left ventricle at the end of the diastole is less. And however, the left ventricular and diastolic pressure will be high because of the stiffness of the wall of the left ventricle due to disease, due to ischemic heart disease, due to left hypertrophic cardiomyopathy, due to hypertensive heart failure. The ventricle is stiff and the patient has symptoms of heart failure, left heart failure without left ventricular enlargement. So this is the difference between heart failure with reduced ejection fraction and heart failure with preserved ejection fraction. Uh, Then there's a condition which is isolated uh, right heart failure. Let's see that isolated right heart failure. In this condition, the left ventricle is normal, but the right ventricular cavity is the first hypertrophy of right ventricle occurs, then it's dilated, and this can happen due to pulmonary hypertension. If the pulmonary hypertension is due to lung disease, we call it pulmonary. And if the patient is having pulmonary hypertension without any cause, then of course the right ventricular heart failure is due to primary pulmonary hypertension. Pulmonary valve stenosis can also lead to right ventricular failure and subsequent right atrial enlargement and symptoms of right heart failure. So, the right heart failure, isolated right heart failure, uh, can occur due to lung disease, when we call this condition pulmonary, pulmonary hypertension, primary pulmonary hypertension, or pulmonary valve stenosis, or chronic recurrent pulmonary embolic phenomena. The risk factor for left ventricular failure, of course, the commonest is hypertension, and then after that, the more coronary artery disease, acute myocardial infarction, well, valvular heart disease, particularly uh, severe mitral regurgitation and severe aortic regurgitation can cause heart failure with reduced ejection fraction. Alcoholism, of course, is a cause of uh, uh, muscle damage, left ventricular damage, and cardiomyopathy. Viral myocarditis can lead to left ventricular failure. Diabetes with microvascular disease can lead to left ventricular failure. And similarly, in newborn and in young children, large patent ductus arteriosus and large ventricular septal effect are two important causes of left ventricular failure which you should remember. I will discuss in heart failure what is preload and what is afterload. Preload is actually increase the volume of blood in the left ventricle at the end of diastole. So more is the venous return, more is the left ventricular and diastolic volume, and more is preload. And similarly, in patient with heart failure with reduced ejection fraction, the left ventricular cavity is dilated and accumulates a lot of blood. So, in you can say that in patients with heart failure with reduced ejection fraction, the left ventricular preload is high. Afterload is the resistance against which the pressure against which the left ventricle contracts to pump the blood into aorta. The examples of increased afterloads are, of course, systemic hypertension and tight aortic stenosis. So we'll discuss these terms preload, what is preload and what is afterload in heart failure. You can see in this picture that there is scar in the left ventricle, which is here due to myocardial infarction. Then there is dilatation of the left ventricular cavity, increased volume of blood in the left ventricle, and then there is high left ventricular and diastolic pressure transmitted to the left atrial pressure, leading to left atrial dilatation, and then through pulmonary veins the pressure is transmitted into the lung vessels. And when there is an increased hydrostatic pressure in the pulmonary capillaries, there is exudation of fluid into the interstitial space and into the alveoli. And this leads to the symptoms of heart failure. The most important symptom of left heart failure is, of course, dyspnea, orthopnea, paroxysmal nocturnal dyspnea. These three symptoms are due to congestion of lung due to exudation of fluid into the interstitial spaces and into the alveoli. and which cause breathlessness. And then after some time in patient with heart failure, that blue vessel shown, it start constricting, and then patient start to develop pulmonary hypertension. And when patients start pulmonary hypertension, then there is a right ventricular dilatation. The right ventricle is shown in blue. This chamber starts dilating. So initially your patient was having isolated left ventricular failure, but now he's having left ventricular failure as well as right ventricular failure. So this patient is now suffering from biventricular failure or congestive cardiac failure. You should not just understand what is left ventricular failure and what are the signs and symptoms of left ventricular failure, and what is congestive cardiac failure, and what is isolated right ventricular failure. The symptoms of left ventricular failure is, of course, dyspnea, which is breathlessness. Dyspnea is then classified according to its severity, NYHA class 2. Dyspnea is dyspnea at rest or dyspnea at minimum exertion or ordinary activity is NYHA class 2, and the dyspnea at minimum activity is NYHA class 3, and dyspnea at rest is NYHA class 4, which is the more severe form of dyspnea. Orthopnea is dyspnea which worsens on lying flat, but it improves immediately after the patient sits and leans forward. And paroxysmal nocturnal dyspnea is severe dyspnea which occurs after 4 to 6 hours of sleep, and the patient wakes up in the early hours of the morning with severe breathlessness and wheezing, which relieves or improves after about half an hour after some medication and treatment. Fatigue in left ventricular failure is, of course, and congestive cardiac failure is, of course, due to poor tissue perfusion, and basal captations are due to exudation of water and fluid into the interstitial spaces in the lung and in the alveoli. These are the crepitations or rails in left ventricular failure are fine crepitation as compared to coarse crepitations of pulmonary fibrosis or bronchiectasis. I've discussed this slide already. The patient is having NYHA class 2 dyspnea, the symptoms at ordinary activity or routine activity. NYHA class 3 dyspnea, symptoms at less than ordinary activity, just like walking few steps, going to toilet. And NYHA class 4 dyspnea, patient is breathlessness at rest. So these are the different classifications. We will say that my patient is suffering from heart failure and is having is an NYHA class 2 or class 3 according to the history, what type of dyspnea he is suffering from. So this slide shows the symptoms and signs of congestive heart failure. You can see the patient has to use, on the right side you can see top right, the patient has to use more pillows. He cannot lie flat. He is orthopnic and his breathlessness at rest. So he use more pillows. And then you examine the feet. You'll see there's swelling of feet due to edema, and the patient who is persistently lying on bed, you should look for sacral edema. The breathlessness grades I've already discussed, NYHA class 2, 3, and 4. Distension of abdomen in patient with congestive heart failure most commonly is due to enlarged tender liver and ascites. Cough with frothy sputum is indicative of fluid in the alveoli, and the patient needs treatment in the form of diuretics. Nocturia in patient with heart failure is due to absorption of edema fluid at night in lying position. So there's increase in the intravascular volume, and then there's increased urination. Confusion in patient with heart failure is of course due to decreased poor brain perfusion. So we discussed these symptoms. Dyspnea is great. We have discussed orthopnea, paroxysmal nocturnal dyspnea, as well as edema and fatigue. And we have also discussed the signs of right heart failure. Most important sign is raised JVP due to dilatation of the right ventricle, right atrium, and congestion of the right atrium, increase right atrial pressure, and of course hepatomegaly and edema of feet. In this picture, you can actually see raised JVP. You should look at the internal jugular vein for pulsations, and you can also you should also remember that raised JVP is not only a sign of congestive cardiac failure, it is a sign of isolated right heart failure. The pericardial effusion and constrictive pericarditis, JVP is raised, increased blood volume in chronic renal failure due to increased blood volume, JVP is raised, and then in JVP is also raised in superior vena cava obstruction, which of course that JVP is non-pulsatile. You can see the pitting edema. You should press the ankle for 30 seconds, and if the patient has edema, you will see a dip. And this is pitting edema in patient with congestive heart failure. You order X-ray chest for cardiac enlargement. Complete blood examination is important to rule out anemia, because anemia is a precipitating factor for heart failure. Raise TLC to rule out any infection precipitating heart failure. ECG is also very important, whether to see this patient is having heart failure, myocardial infarction, ischemic heart disease. Echo is also important to see left ventricular size, left ventricular ejection fraction, any thrombus in the left ventricular cavity, left atrial measurement. So this is very important investigation in congestive cardiac failure. You can see nicely on the left side, the heart is left ventricle is enlarged and is almost touching the chest wall, whereas on the right side, the heart size is normal. The treatment, you should advise your patient there should be strict sodium restriction and low fat diet. You should lose body weight and you should perform moderate physical activity. You must quit smoking and you must stop alcohol and caffeine because caffeine also causes tachycardia. The purpose of the main aim of treatment of heart failure patient is to improve his symptoms so that he feels better, and then improve survival of the patient and the improve quality of life of the patient. So digitalis and diuretics and nitrates, they improve symptoms. The patient feels better and he feels more comfortable. But these drugs has nothing to do as well as the survival benefits are concerned. A number of trials have shown that beta blocker like carvedilol and bisoprolol and metoprolol, when given in low dosage, improve survival in patients with heart failure. Of course, these drugs have to be started when the patient is in hospital for 2 or 3 days. The patient must be edema free, no chest crepitations, no JVP. The systolic blood pressure is more than 90 millimeter of mercury, and the pulse rate is more than 60 beats per minute. So these are the guidelines for starting beta blockers. A number of trials have shown that ACE inhibitors are beneficial in patients with congestive cardiac failure. They improve morbidity as well as mortality in patients with heart failure because there is increased renal angiotensin system activity. There is increased catecholamine level in the circulation. Then catecholamines are cardiotoxic and they are arrhythmogenic. So ACE inhibitors are very helpful. And if the patient cannot tolerate ACE inhibitors, you should put him on angiotensin receptor blockers, of course, ARBs. Spironolactone, which is aldosterone uh, blocker, aldosterone antagonist, is a very effective drug in reducing cardiovascular morbidity and mortality. Results trials have shown that giving 25 milligram of spironolactone to patient with heart failure on top of beta blockers, ACE inhibitors, other treatment reducing mortality. Of course, you should keep an eye on serum potassium while you're prescribing aldosterone blockers. Ivabradine is a drug which is very helpful in reducing cardiovascular uh, mm, mortality and hospitalization due to heart failure in SHIFT trial. This drug should be given, the dose should be started at a dose of 2.5 milligram, and then you can gradually upbuild the dose to 5 milligram and 10 milligram. And then uh, we come to the biventricular pacing. Uh, Sometimes we send these patients to electrophysiologist for biventricular pacing, where a lead is produced, put in the right ventricle and other in the coronary sinus, so that there is synchronous contraction of left and right ventricle. And the indication for biventricular pacing are um, left ventricular failure, ejection fraction less than 35, and broad QS complexes. Sudden cardiac death is quite common in patients with congestive cardiac failure, particularly if these patients have suffered from an episode of ventricular tachycardia or ventricular fibrillation while in coronary care units. These patients should be referred to electrophysiologist for the uh, intracardiac defibrillator, and this device shocks the ventricle immediately once it detects ventricular tachycardia or ventricular fibrillation. And the indication for ICD is, of course, dilated ventricle, heart failure with reduced ejection fraction less than 35, and patient have with dyspnea, NYHA class 2 or NYHA class 3. Heart lung transplant is, of course, is not done in our country, but in other part of the world, um, it is done rarely in few patients uh, mm, in whom the therapy is not helping. The other therapies which I have mentioned to you are not helping. The patient is not improving. Then you can, of course, go for heart transplantation. So, heart failure is very common. It has a high mortality, has a high rate of patient has a high rate of repeated hospitalizations. You should give drugs to improve his symptoms, but most importantly, you must give drug to improve survival, like beta blockers, ACE inhibitors, spironolactone, scubitril. Valsartan is a new drug which reduces cardiovascular mortality. In a paradigm heart failure trial, it has shown that there is significant reduction in cardiovascular mortality and hospitalization to the due to heart failure. And similarly, ivabradine in SHIFT trial has shown significant reduction in cardiovascular mortality due to heart failure. I've already discussed biventricular pacing. And finally, acute pulmonary edema. A patient can present to you with an emergency with sudden severe breathlessness. On examination, the patient is cyanosed, he is breathless, there is tachypneic, and there is pulses alternate. The blood pressure may be low or very high, and the this patient is suffering from acute left ventricular failure. If you ask the history, there might be history of accelerated hypertension, acute aortic regurgitation, in infective endocarditis, particularly acute valve regurgitation, a myocardial infarction, acute myocardial infarction with rupture of papillary muscle. These are the causes of acute pulmonary edema. Or sometime in patient with uh, the compensated heart failure, they suddenly go into acute pulmonary edema due to some precipitating factors. The treatment in this again shows that there is increased load of water on the alveoli. The alveoli are filled with water and RBCs due to high left ventricular and diastolic pressure. Suddenly, suddenly goes up, and there is a high left atrial pressure, and then there is a high pulmonary capillary pressure, and of course, there is pulmonary edema. Uh, Sinus system symptoms I've discussed already. There's wheezing, there are crepitation, frothy pink sputum, of course, due to the fluid, accumulation of fluid in alveoli. The patient is cyanosed because of hypoxia, and then there is tachycardia. The patient may be in shock, and there's S3 gallop. You give high dose of oxygen, and if the saturation doesn't improve, you of course then intubate the patient, and you may put patient on ventilator. Morphine is very helpful in decreasing the anxiety as well as in reducing the preload and afterload, because it is a venodilator and it reduces the sympathetic activity, it reduces the heart rate. And then, of course, we give intravenous nitroglycerin, which reduces the preload. Diuretic should be given a very high dosage, irrespective of the blood pressure of the patient. Even if the patient's blood pressure is 80/60, you give high dosage of furosemide, say 80 milligram, 160 or 320 milligram till the pulmonary edema is over. Don't worry about the blood pressure. Once the pulmonary edema is over, the blood pressure will come up. And then you should repeatedly measure oxygen saturations and blood gases. So this was all about the heart failure. Thank you very much for your attention.